It's my pleasure to introduce Dr. Yael DeVere, who's the Vice Chair and Director of Child and Adolescent Psychiatry, who will introduce today's speaker.
Thank you, Tony. I am very happy to introduce Dr. Sarah Vinson, who is our grand round speaker today. Dr. Vinson is the interim chair for the Department of Psychiatry and Behavioral Health at Morehouse School of Medicine, and also the Child and Adolescent Psychiatry Fellowship Program Director there. She received her undergrad degree at Florida A&M University, and then medical degree at University of Florida College of Medicine, trained in psychiatry residency at Cambridge Health Alliance, and then proceeded to do 2 fellowships in child and adolescent psychiatry and forensic psychiatry at Emory School of Medicine. So she is a triple boarded child, adolescent, adult, and forensic psychiatrist. After her training, she joined faculty at Emory School of Medicine and also Morehouse School of Medicine, where she was co-course creator for the forensic psychiatry elective, which she continues to direct, and initiator of the partnership with the Department of Juvenile Justice. She's also medical advisor for SAMHSA African American Behavioral Health Center of Excellence, and really a national thought leader on the intersection of social justice, criminal justice, and mental health, and sits on a number of boards. Her research interests are in social justice and mental health, decriminalization of trauma and mental illness, and Black mental health. Very much looking forward to hearing your talk, Dr. Vinson, because you received excellent reviews from the trainees that you met with earlier. So I'm now happy to hear your talk. Thank you so much.
All right, good morning. And I wish I could hear Dr. Pinel's talk. The forensic psychiatry world is not that big, so we all know each other, and I'm sure she'll do a fantastic job when you guys have her in a couple of weeks. But happy to join you this afternoon. As mentioned, I do child forensic and adult work. And I think the other thing that's really relevant for this talk, and just for you all to perhaps hold in mind about my perspective professionally, is that I've also done public sector work and private sector work throughout my career. And so a lot of the inequities that I'm talking about here are things that I see, and the difference between my private practice patient on Monday afternoon and what I see in the public sector clinic on Tuesday with my residents and my fellows. Whenever I'm giving this talk, I always have to acknowledge Dr. Ruth Shim, who I understand you guys have had here before, but she is a friend and mentor, and she was the co-editor of the book, Social Justice and Mental Health. So what's ahead? We'll talk a little bit about some key concepts as part of the introduction, the mental health care system, child trauma, the carceral system, substance use disorders, advocacy, a call to action, and discussion. And so I will go by pretty quickly because I want to give us some time for a discussion at the end for sure. So I'll start with, how do you define mental health? And this may seem like a really elementary question to ask a group such as yourselves, but I think it's an important one because so many times in medicine, even when we say mental health, the focus is really on mental illness. It's on symptoms, it's on diagnoses, it's on disease states. We spend a lot less time talking about what is the optimal state that we would like people to be in or what we would like to push them toward. So the World Health Organization says mental health is a state of well-being in which every individual realizes his or her own potential, can cope with the normal stressors of life, can work productively and fruitfully, and is able to make a contribution to her or his community. And I welcome you to reflect on that definition and how it has nothing to do with DSM diagnoses or symptom rating scales or medication adherence or any other things that we spend so much time writing and talking and thinking about. It has a lot to do with people's environment, with their community, with the choices that are available to them or not in the society that they're in. It is very structurally and socially mediated. So a conversation about mental health is one that by necessity has to include a conversation about society and these broader social issues.
Which doll is the black doll? And which one is the white doll?
That one.
Which doll is the pretty doll? Which doll is the nice doll? Which doll is the bad doll? Which doll is the nice doll? And which doll is the bad doll? And why is that doll pretty?
Because she's white and he has 2 eyes.
Which doll is the ugly doll? Why is that doll ugly?
Because he's black.
Which doll looks most like you?
Like me?
Yeah, which one looks like you?
And that one.
Okay.
That doll.
So some of you probably recognize that, or in concept at least. It's a fairly recent recreation of the Clark doll experiments that were used to argue for desegregation of schools. And the psychologist team, the Clarks, presented this as an illustration of the ways that racism is harmful to children, right? And I play this clip for a few reasons. So if we think about that definition of mental health and where we want people to go, we can't really have that discussion without thinking about social hierarchy and marginalization and how that plays out in people's ability to achieve that idea of mental health, or even their ability to see themselves in that place. And of course, this focuses on race, but we know that there are hierarchies along all kinds of areas, right? Race is one of the more readily identifiable ones. But I play this because this is still very relevant. And if you had a white kid do this or an Asian kid do this, they would also know who is the black doll, who is the bad doll, who's the ugly doll, who's the stupid doll, right? And so we all grow up with these messaging. We all grow up with these narratives. We carry them forward. And it's naive to think that it wouldn't affect how we do our jobs, how we function in the mental health field, even how some of the things in our field are written or set up. The things we pay attention to, the things we don't, the things that we prioritize in terms of health and funding and things like that, and that we do not. And so these issues of hierarchy and narrative are mental health issues, and they're ones that, whether you want to or not, you're going to carry into your treatment room, into your classrooms, and into the different spaces where you are as a physician. James Baldwin said, if you're treated a certain kind of way, you become a certain kind of person. Things are described to you as being real. They're real for you, whether they're real or not. And I think that as we think about mental health and development and identity, these societal issues are going to play a major, major role. So again, thinking about health, we know as mental health professionals, things like agency, safety, and autonomy are key. And again, these are things that society is going to have a big role in determining. So one of the things that I like to sit with a bit before we launch into this talk is just to acknowledge the American dream and the different connotations that has for everybody in this room. Now, for medicine as a whole, or for people who have the privilege of getting a terminal degree as a whole, many of them started off middle or upper class to begin with. Or if they didn't, they're people for whom the American dream worked, where education and hard work resulted in this change in your social status and allowed you to achieve things that maybe people in your family hadn't before. So that idea of upward mobility was one that either wasn't needed for people or it worked. That's not representative of the societal experience at large necessarily. And if you're doing public sector mental health work, it's certainly not representative of the experience of the people that you are serving. So there's this disconnect between our ideas of what society is and how it operates based on our lived experience versus what's brought into the clinics with the people we serve. I remember, we've had some interesting conversations these past few years, and after George Floyd's murder, there were all these people that were like, oh my God, I can't believe this happens. And I'm like, this has always happened. This is not new. It's a privilege that you are just now figuring that out now, right? And so the ways that people come to you, the things that people come to you with, it's always important for us to hold in the field that we have a gap, right? When you look at us as a whole, we are a privileged group of people. And mental illness in and of itself can be marginalizing. If you're working in public sector mental health settings, then you have that layer. If you're working with minoritized racial groups, you have that layer. So there's a gap between where we sit and where the people we serve, or the people whose problems we're trying to understand, sit often. If you've ever been to England, you ride the subway there. There's this announcement. It's borderline obnoxious. It says over and over again, mind the gap, like the whole thing. They have t-shirts and everything, right? They say it so much because it's so important, right? Because the consequences of not minding it is that you end up in between the platform and the train. And I bring it up because it's one of these things that as mental health professionals, we have to do, especially given the nature of our work and the things that we're called to understand and that we say we are treating and addressing. So I also have to acknowledge that not everyone in the House of Medicine feels this way, right? And there are some states where it's becoming increasingly difficult to talk about these things. It's important to acknowledge that tension is there. And that, you can probably guess what side of the line I'm on, but that these are things that are ongoing discussions within our field. And there are some folks who would say, you dedicating a grand round slot to this is peripheral to the House of Medicine. And so that's there. And I want to acknowledge that element as well. So let's get to social justice. There are different definitions of social justice. And I think this is one of those things that's kind of been politicized. And when that happens, it's useful to just go to a definition and see what it actually is. And so this is one by John Rawls. It says, assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. Well, that doesn't sound all that controversial, especially if you're a physician, right? And so this idea of liberties, rights, and opportunities has some overlap, right, with that idea of mental health and what it takes to attain that. So some principles of social injustice. And as I talk about these principles of social injustice and the next slide related to oppression, I would welcome you to think about how these things could influence the development of mental health symptoms, how it could influence patient-physician dynamics, how it could influence the diagnostic process for you. So some principles of social injustice: essentialism, the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. I also welcome you to think about how you may have heard this come up in your training or in your education. So for instance, those very well-intentioned cultural competency seminars that say, Black people do this, Southeast Asians do this, Hispanic people do this, right? You're reducing a very complex, multifaceted, diverse group of people into a set of things you're supposed to know to be culturally competent. Erasure of context, failure to consider socio-historical context when seeking to understand the etiology of inequities, biological determinism, the false belief that racial groups are biologically and genetically different, and then types of oppression. And I welcome you to think about how these things would block somebody from attaining that mental health definition, even if they don't have something that's a diagnosable DSM condition. And also think about how this might contribute to those diagnosable conditions. So exploitation, the unequal exchange of one group's labor and energies for another group's advantage and advancement. Powerlessness, oppressed groups lack power and are blocked from routes to gaining it. Marginalization, expelling specific groups from meaningful participation in society. Violence, when there are threats and experiences of physical and structural violence. And by structural violence, I'm referring to violence or harm that's mediated by systems. And cultural imperialism, so establishing the ruling class culture as the norm and othering of groups that are not part of the dominant culture. Another example of this, you go back to those cultural competency seminars. I'm sure some of you have had them or been in them. Has anybody ever been to one where they talk about white culture? For those of you on Zoom, nobody's hand is going up, right? That's because it is the invisible norm that everything else is compared to. That is an example of cultural imperialism. So health disparities. So you all know this, you've heard this before. I'm giving you this to draw a contrast, but these are differences in health status among distinct segments of the population that can occur by gender, race, ethnicity, education, income, disability, any number of things, right? But disparities just says there's a difference. Oh, golly gee, that's interesting. Inequities places disparities in context. It says that disparities, that these differences are a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So there's an explicit acknowledgement in saying inequity rather than disparity, that these things are by design, that they are addressable, and that it's not just a difference, but it's set up to be different. And that's really important. It may seem like it's just semantics, but if you say disparity, then, oh my, that's an interesting study finding. If you say inequity, then there are things you can actually do to affect the drivers to close the gap, if that's what the intention is. So when we talk about social determinants of mental health, and it's great that we're talking more about social determinants of health, by the time they're in our clinic and we're discussing it, the exposure to that adverse social determinant of health has already occurred, right? You're already dealing with, especially by the time they get to us, you're already dealing with the negative mental health impacts of homelessness and climate change and discrimination and poverty. Our society has resources. We know these things are harmful to people. We've studied them for many, many years. This isn't new. And so how is it that so many people in our society that has the resources that could address these things are consistently exposed to them? And that is fundamentally a social justice issue because it's allowed to happen because of the unfair and unjust distribution of opportunity. And what drives that, or the bedrock of that, are your public policies and your social norms. And the two of those work in reinforcing ways to create this setup where you have these issues affecting such large swaths of the population. And you all know as mental health professionals that these adverse social determinants of mental health lead to reduced options, behavior risk factors, physiologic stress responses, and psychological stress, and the things that we end up diagnosing and trying to treat. So let's talk a little bit about the mental health care system, and I'm going to fly. So as I said, I want to give us time for questions and comments at the end. But the book chapter authors for this system really start out with a question about, is this a misnomer to call it the healthcare system? And here's why. So the name implies the provision of health, but providers and policies focus on the provision of clinical services rather than the promotion of health. And we talked a little bit about this with the residents this morning. Care suggests services involve meeting the needs of patients, but services are more centered on the needs of providers and the bottom lines of payers and shareholders. System implies an organized, cohesive, connected structure rather than the public-private patchwork of hospitals, clinics, private offices, and health system conglomerates that make up healthcare. And I'll say, in Massachusetts, you're better off than a lot of the rest of the country from a system standpoint, but I'm sure you all would tell me it's not perfect here either. And so let's take private health insurance as an example. So we know that this is a mediator of access because if you have a private payer, even something as basic as integrated care billing codes. So in Georgia, if you have Blue Cross Blue Shield, it will pay for doc to docs in a child integrated care clinic. If you're on the managed Medicaid by Blue Cross Blue Shield, it will not. And so whether you have private insurance or not can be a big determining factor of what your experience is like trying to access services, or even at what point you're able to access services. And who gets private insurance is dictated by what kind of job you have in this country, right? And so structural processes like underinvestment in education, career paths, hiring discrimination, all of these things result in a situation where, to take one marginalized group as an example, Black and Latinx people are disproportionately represented in uninsured and those with public insurance. We look at hospitals. Where they are is not necessarily about where they're needed, but they are influenced by residential segregation, imperatives to generate revenue, and state policymaking. And then let's look at physicians. Now, we know that physicians aren't the entire mental health workforce, and they're not even the majority of the mental health workforce, But I still think that this is illustrative and helpful for us to just consider. When we think about that gap, that mismatch between providers and the population is quite pronounced. So in 2019, only 5% of medical students reported parental incomes in the bottom quintile of US household versus 51% in the top. From 2010 to 2016, mean debt rose, but the zero debt also rose from 16 to 27%. So more than 1 out of 4 physicians are from a family that can write their checks all the way through medical school and let them graduate with no debt. And what do you think, or what do you know, is the most consistent predictor of practice in communities with chronic underinvestment? Is that people have connections to those communities. We are training a workforce that by design does not have connections to those communities. Then we wonder about physician workforce shortages in rural America and in impoverished areas. So what does this create, right? It creates a situation where people in marginalized groups, and I'm just going to use Black and Latinx folks as an example here, but again, I welcome you to hold in mind marginalized groups as a whole as we're going through this. 69% of Black adults with any mental illness received no treatment, and 42% with serious mental illness received no treatment. We look at Latinx folks, and the 67% received no treatment, and 44% with serious mental illness received no treatment. And there are systemic barriers to this. So, right, so we have the access to private insurance, but then we have the ways that within medicine, mental health is marginalized. And so we're dealing with all of these things, even though we have parity on the books, we don't necessarily have parity in practice, and the degree to which we do varies state to state. And so you have a lot of psychiatrists in private practice who opt out of a system because of how underfunded it is, right? And so the disparity you see, or the inequity, rather, you see between mental health and physical health care is pronounced in where our providers choose to provide service, with the proportion of mental health services received out of network being 3.6 to 5.8 times higher than other medical specialties. So a lot of times you go and you hear about Black mental health disparities or Latinx mental health disparities. They say, oh, you know, they pray about it. They go to church. They have cultural stigma. They don't understand these things. And I'm not saying that those things aren't relevant at all, but there's very little discussion of the unique barriers that these populations face to accessing care. And Elaine did a study in 2019 and just, actually asked Black people why they don't get mental health services. And the response was that cost was the most commonly cited reason for not seeking care, twice as often as minimization of symptoms and nearly 5 times as often as stigma. So when you focus on stigma, the answer is you put up some posters and you have pastors talk about it. If the driver is cost, then we have to reevaluate and rethink how we're providing services and how we've set our systems up. And you can see why all those stigma campaigns haven't really moved the needle a whole lot. Substance use disorders. So this is an area that really illustrates that societal narrative public policy interplay. And so what you see sometimes with substance use is that there's this moral panic, public concern in ways that you have these reactionary policies to it. So we know that there is a significant inequity when it comes to cocaine and crack, in part because of what populations of people are associated with these things. And, this could be a whole talk in and of itself. I won't stay here for long. I'm assuming you have some familiarity with this. But what you saw was that because of how a substance use disorder was characterized, the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. That was the response to this particular substance use disorder. Contrast that with a substance use disorder that is associated with a different population, with a population that's not on the margins, with a population that reminds lawmakers of their niece or nephew. And, DSM, same SUD criteria, whether it's crack or opiates, right? But the societal response has been radically different, in part because of the societal narrative. So when you're talking about moms with crack issues, you say, in the Washington Post, crack babies, the worst threat is mom herself. Whereas when you're talking about opiates, it's children of the opioid epidemic. And there's this very sympathetic picture and this mom who wants to get it right for her children. Still a substance use disorder. And even when it comes, and it would be one thing if this was just this was just a difference in headlines, right? But this difference in narrative is followed by resources or not. So if you were to go onto the APA website, and maybe they've changed it because I keep picking on them, but I don't think they have. If you were to go onto the APA website and look at their substance use disorder page, you would swear opiates are the only drugs anybody in America is using. Black men are dying from cocaine at the same rates white men are dying from opiates. You would have no idea, right? And it's not just that that's their page, but they're offering trainings about opiates. You look at where NIMH is putting money, it's for opiates, right? And so it's not just a page, but there are resources, there are training opportunities, there are who you're setting up the workforce to be able to take care of. That is driven by this for the same disorder. So when we think about those health inequities and treatment and access to treatment, those numbers are even worse for our two marginalized groups we're focusing on right now, with 89% of Latinx adults with substance use disorders reporting receiving none, and 88% for those who are Black. And, you know, I'll tell you all, and I won't spend too much time on this, but I grew up in Northwest Florida, a small town called Pace. I'm sure none of you have ever heard of it, but I had people in my extended family who were impacted by trauma and substance use disorders. And I literally did not realize until I went to medical school that people could get treatment and care for addiction. Everybody I knew went to jail. Everybody. And when I was in medical school, I was on a substance use unit, and people were using, actually at that point, they were using kind of all the same drugs. Everybody who was Black had been incarcerated for it. Nobody who was white had. Same drugs. And that was part of what got me interested in psychiatry, actually. So child trauma. Some of you may know Dr. Judith Herman. When I trained at Cambridge, I had the opportunity to train under her, which was absolutely a formative experience for me and impacts every aspect of my work, especially the forensic work, actually. But one of the things she says in Trauma and Recovery, which if you haven't read it, you should read it. She has a new book out as well. But she describes this concept of complex PTSD. And she says the developing child's positive sense of self depends on the caregiver's benign use of power. And one of the main arguments in her book is that when you have trauma that is in the context of relationship, that is inescapable, that happens over an extended period of time, that impacts and shapes you in a different way than a trauma that's a one-off, which is the one that our diagnostic criteria is really written to capture. And I would argue that when you're talking about these issues of justice, when you're talking about structural trauma, there are a lot of parallels between that and this complex trauma that she describes. And her new book gets more into some of these structural issues. So these are three people I met in different settings. One was an adult defendant in a capital murder case who said, I was proud to make it to 21, even though I was in prison. I met him as a forensic evaluator. One was a software programmer in my private practice clinic who said, school was all I ever really had to worry about when I asked him about his childhood. And the third was a teenager I saw in it's essentially a jail for kids. They call it a regional youth detention center. That said, they say I'm supposed to care about people when ain't nobody cared for me. And so we know that there are things that set people up to be mentally healthy. There are positive childhood experiences, like having a home, reliable caregiver, educational opportunity, and healthcare access. And child poverty is something that is going to undermine every single one of those things, or put people at risk for not having them in place consistently. 12 million, 1 out of 6 U.S. children live in child poverty. And for those of you who aren't familiar with that threshold, it's $26,500 a year for a family of 4. So there are a lot of people who make $50,000 a year, and for a family of 4 are not going to be able to consistently provide those things that we know that families need. 73% of children of color. And the child poverty rate is nearly 1.5 times higher than that for adults ages 18 to 64. And I point that out because often when we talk about all the isms and when we talk about disadvantaged groups, we don't put children in that category. But by every measure you can think of, and again, this is another talk, by every measure you can think of, children are in marginalized groups, and adultism, interpersonally and structurally, is a major, major issue. And so we think about kids, and this is allowed to happen in a country that spends over $700 billion a year on defense, more than the next 10 countries combined, and where a majority of US lawmakers are millionaires. It doesn't have to be this way. We've chosen for it to be this way. And so it's going to undermine all of those things that we know are foundational and really helpful to set people on the right path. So if we look at Miguel, who said he was proud to make it at 21, even though he was in prison, and I did change his name. He'd been incarcerated in an adult facility from the age of 17 to 21 for a nonviolent offense. He had all of these unmet needs that resulted in DJJ risk factors. And for the sake of time, I won't go through each of these, but all of the things that we know place people at risk for depression, for mental illness, for substance use disorders. It's the same list of risk factors for juvenile justice system involvement. That's not a coincidence. Now, if we were looking at him, looking at his medical records, we probably focus on his symptoms, what he was reporting to you as an individual. We may get to the family issues, and they were significant. And in all of my capital cases, they are, quite frankly. Maybe we start talking about neighborhood violence, and housing and food instability. But we may not talk about as much are things like multi-system failure and the characteristics of the narrative and the narratives of the larger society that enable that failure to happen. So in his case, he'd been in 12 different foster care placements. He had unmet educational needs and for his learning disabilities. He attempted to die by suicide the first time in the 3rd grade when he tried to jump out of a car. And even with that, the system that he was placed in because his parents couldn't take care of him also failed to take care of him. So how did this happen? Well, he's in a state that has a very low per capita mental health spending, one of the lowest in the country, chronic child protective services understaffing. And it was during a time when people were saying things, well, you do adult crime, you get adult time. And so what we see, not surprisingly, when you look at the overlap in those risk factor tables, is that the mental health system for poor kids, kids in rural areas without access, and Black and brown kids is the juvenile justice system. And that's why I started working in the juvenile justice system and started our relationship with Morehouse School of Medicine, because that's where our kids are. 70% of the kids in those systems have mental illness, 30% have serious mental illness. And I would say that that's really an undercount because so many of their traumas are not counted or accounted for. And this leads us to the next topic of whose trauma counts in our diagnostic criteria, in our widely used instruments, and when we, the House of Medicine, the House of Psychiatry, are the bystanders. And in some ways, perpetrators. So as a forensic psychiatrist, I have the part of my job is to try to help a court understand who a person is. And in that role, I end up getting all of these records, child welfare records, mental health treatment records, school records, because in the forensic context, it may be the difference between the death penalty or not, life without parole or not, a 16-year-old being tried as an adult or not. And so, as you can imagine, there's a lot of scrutiny about your opinions. There's a lot of weight that they may carry or not, but you have to be prepared to be cross-examined on everything you say or write or do. And so in a clinical setting, you kind of presume people are basically telling you the truth and nobody's going to cross-examine you about what you write in the chart, whereas it's very different in the forensic setting. So you go through all of these records as part of strengthening your opinion so that it stands up on cross. And so, I may have 20 or 30 hours of record review for a case. And I've seen a lot of people who have had a lot of trauma and a lot of things that should have raised concern for trauma or stress-related disorders, or for mood disorders, or for anxiety disorders, who are just labeled as having oppositional defiant disorder, or just labeled as having conduct disorder. And I've seen how that diagnosis is weaponized in the criminal justice system and used against them, and how it is carried forward in a way that does not serve them well and in fact harms them, because we, as a profession, focus on externalizing behaviors, especially when it comes in the package of a child we've already been primed to think of as bad or criminal. And so there's a way that that's by design, right? When you look at the DSM diagnostic criteria for PTSD, neighborhood violence, racial trauma aren't emphasized, things that impact those communities more. And so the trauma's manifestation may not be caught if you're not intentional about it. And it's easily categorized as something else. The thing about those conduct disorder and ODD diagnoses is they don't require you to have any rapport with the child. They don't require the child to trust you. They don't require the child to disclose to you what's happened in their lives, right? It's a checklist diagnosis. It's an easy diagnosis to make. The ones that require them to trust you and maybe talk about some of their hardships are the ones that often are not made. And when we don't take that step, when we're not thoughtful about it, I tell you, this follows these kids who become adults in these systems and does so in ways that can be very, very impactful. And so there's a way that I hate to tell you all, but that we as a group are part of that marginalization and the racial problems in the criminal justice system. So this is a still of a Black boy who was playing basketball in his front yard, not doing anything wrong. Sees the cop car come by, stops playing, hides behind his parents' car until the cop car goes away, then starts playing basketball again. Now, if you don't understand this child's context, if you don't understand the realities of America, that may seem like strange behavior, may seem disorganized, may seem a little paranoid. And then somebody tells you that this was June of 2020 after the world watched George Floyd die. And they tell you that when his dad asked him, why'd you do that? He said, because they killed George Floyd. Because this child identifies with the man he saw people in state uniforms murder. You can't afford not to think about these things if you call yourself taking care of people who are impacted by them. So the criminal justice system is one that has all kinds of inequities. There are ways that inequity goes viral, but I'm telling you, there are ways that inequity doesn't go viral and just goes into the background noise and impacts families and children and entire communities. Most judges actually acknowledge that the system is racist, even with 80% of state judges being white. And what you see is that sentencing outcomes vary not only by race, but by shade. So you all know this when you're trying to understand does something cost something? You look at dose-response relationships, right? This is a dose-response equivalent for race. So somebody who's my complexion is going to get a harsher sentence than a lighter-skinned Black person who's going to get a harsher sentence than a white person. When you control for the kind of crime and people's criminal record history. So this brings us to advocacy. So the goal, and I won't sit here long because I want us to have time for questions. But I think this is helpful to visualize the difference between equality, which is where you're giving people the same things, and equity, which is where you're giving custom tools that identify and address inequality. And ultimately, right, you would long for a society where justice is there and the system itself is fixed. James Baldwin said, ignorance allied with power is the most ferocious enemy justice can have. As physicians, as people who are giving people diagnoses, as people who are addressing their problems or helping them address their problems in a meaningful way or not, you all have tremendous power. Some of you may recognize this man. He was one of the formerly known as the Central Park Five, now known as the Exonerated Five. I got to interview him a few years ago. And one of the things he said was, we don't need everybody to go be politicians. This is a big problem. We need all hands on deck. And I couldn't agree with him more. There is something that everybody can do, just given how pervasive these issues are. He was falsely convicted at 14, spent 7 years in the carceral system. And then after they knew they had locked him up for his adolescence for something he didn't do, still took 12 years for the state of New York to settle their civil claim. I told the residents this story earlier, so I won't tell it again, but there's a story about secession. The moral of the story is not every role is for everybody, but the role that's for you is for you, and there is work for you to do in this space, in whatever role you currently inhabit. Oh, but I will ask you these three questions. What do you feel deeply inspired by? What are you particularly talented at? And what addresses injustice in your world? So some things I would ask you to do, and I'm really glad you all came to the talk today, and I appreciate it, but coming to the talk is not the work. The work is recognizing injustice and your role in addressing it, responding to the injustice, and then iterating and sustaining. So actually measuring to see if what you're doing is closing those gaps that you're trying to address. And there are all kinds of ways to do this. So in the top right corner is Dr. Joe Bona, who actually passed away in spring of 2020. He was a great mentor of mine. He was white male doctor from upstate New York who was from a line of doctors and was this tremendous mentor for me, a first generation doc from rural Northwest Florida, right? And he did a lot of work at the state level around public sector psychiatry in Georgia and did so quite effectively. Dr. Nell Prim, who some of you may know, was at the A.P.A. for many years, used organized medicine and programming through it to advance health equity. Judith Herman, in her book, Trauma and Recovery, and now her latest book, really brought attention to the traumas of people from marginalized groups that weren't centered the way that other traumas were. So there's a way that you can do it through writing, right, and through contributing to the literature. And then as educators, right, making sure that we incorporate these things into how we're teaching our trainees and the exposures we give them. So for example, at Morehouse School of Medicine, the Clark doll study is one of their articles for Journal Club. Our fellows also rotate with child lobbyists during the legislative session so they can understand how the legislature works and sometimes doesn't work. And I'll just introduce this concept to you. I won't go into it too much, but part of this work, part of being able to sustain this work is recognizing that it is hard and just radically accepting that it is hard and that it's going to be uncomfortable and it's going to be emotions that are brought up by it, but not letting that deter you from it. And so in that discomfort is also retrenchment, which I want to acknowledge as well. And we're certainly seeing that now. Systems, societies don't like to change. Homeostasis isn't just a thing we learn about for our bodies. It's something that happens in society too in a lot of ways, right? So as change starts to take hold, or people are even fearful that change is about to take hold, even if it hasn't really, there will be pushback. We've seen this at every stage in our country's development. You didn't have the KKK before the Civil War, right? And that is something that we have to be aware of and prepared for and understand that that's part of the process as well. So going back to the very top of the talk, how can every individual realize his or her own potential, work productively and fruitfully, and make a contribution to her or his community? That's our definition of mental health. In a society that fails to assure equal access to liberties, rights, and opportunities, and chooses not to care for its least advantaged members, our definition of social justice. And I would posit that it cannot, that without justice, we will not have peace. So I'll end with a quote by John Lewis, my former congressman in Atlanta. It says, "Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." Thank you all.
Questions from the audience?
Thank you for that really wonderful talk. And, this has been a particularly difficult couple of weeks when we see something like a kid knocking at the door of a house and being shot, just in all likelihood because of the color of his skin. And this is a child. So I would just be interested in your thoughts on an event such as this, and what can we do as a community to educate ourselves and try and heal ourselves when something like this happens?
Yeah, thank you for that. And it's and I mean, interesting is not the word. What's tragic is that that's like one of 5 events in the past week of kids just making an honest mistake. And one young woman who's a white woman was killed driving out of the driveway. didn't even go up to the door. And so there's, but it illustrates a really interesting point. So Michelle Alexander, if you're interested in these issues, The New Jim Crow is a must read. I make our students read it for their forensic elective. But one of the things she talks about in that book is that mass incarceration, even though the main group impacted by it are, poor Black and brown people, there are white people that get caught up in that too, right? It doesn't, when you do something like that, it doesn't stay contained in that group. Maybe it doesn't get as much attention because of who it primarily affects, but it's not safe for society as a whole. And I think some of the things that this past week have illustrated is that when you have so many guns and so much angry rhetoric, it's a setup, and it doesn't allow any of us to be safe. And I think the more people can understand that, maybe the more motivated they'll be to start to address these things. But, if you're working with Black families, that might be front and center for them this week. That may be something that's on their mind. You may see increases in symptoms, and they may not even make the connection because you have to keep going, and you have to do, and you have to get things done. But I would say being aware of those things, maybe opening up conversations around those things as a clinician and as a provider is important. And then just continuing to use your settings like this to call attention to these issues so that they are front and center for us, because they're front and center for me by default. They may not be for other people, right? And so there's an intentionality you have to have around it when that's the case. But I wish I had an answer because it's really scary. It's really, really scary, and it's hard to see how this gets better unless serious action is taken. But it's hard to see serious action being taken.
There's a lot of comments about your talk being very powerful online, but one person said that you had a slide of things to do that if you could go back to because you sped by it a little too fast and people want to absorb it. I had a question and a comment. There's my area of interest is psychotic depression, and there have been some interesting studies done broadly that when African Americans seek mental health treatment, they're more likely to be diagnosed with schizophrenia than a mood disorder. And I don't know if you had any thoughts on that, because the thing you worry about in psychiatry is even though we have this DSM-5, there is some subjectivity to it in how you interpret it. And so I just was wondering if you could comment on that.
Yeah. Lots of thoughts on that. A few things. So going back to that American dream slide and idea, right? If America is the land of the free and the home of the brave and the seat of liberty and justice for all, then how do you explain it being built on the genocide of Indigenous people and the enslavement of Black people? How do you hold those two things, right? And part of how we've done that as a society collectively is we've literally marginalized Indigenous people, so they're like out of sight, out of mind. And when it comes to Black people, there's this thread of them not being like quite fully human in the same way. And in medicine, maybe that shows up as medical students thinking Black people have a higher threshold for pain and not as many nerve endings, which is a study that is not that old, that quite recently came out, right? Because if we embrace the full humanity of Black people, then we have to face some hard truths about our country. And so the choice has been, we maybe don't do that. And so I think there's a way that that's connected to us not being able to recognize mood disorders in marginalized populations in the same way, because their pain is not recognized. their full scope, their ability to feel all the emotions is not recognized. And if we start to acknowledge Black people's pain, we have to acknowledge where some of that's coming from. And that doesn't paint the best picture of our society either. You pair that with, how many of you have read Protest Psychosis? Got one hand. Okay, so Jonathan Metzl is an anthropologist and a psychiatrist. If I had known what anthropology was when I was an undergrad, I would have been an anthropologist too. But it's a really interesting book about the way that schizophrenia went from being a diagnosis that was mostly given to white women to being given to Black men around the turn of the civil rights movement. And there was more of an emphasis on things like paranoia and anger, right? And so, and I think that it being given to white women is interesting too, though, because it was like women who weren't excited to do the dishes and the things women are supposed to want to do. So there was an element of it like being used to enforce a social hierarchy there too. But all that to say, I think the combination of it's hard for society to fully embrace the full humanity of Black people for a lot of deeply entrenched, complicated reasons. Plus, when you're already primed to be afraid or to dismiss Black people's concerns as paranoia because you don't understand where those concerns are coming from, it sets up a situation where you may be more likely to make a primary psychotic disorder diagnosis. If you are looking at that boy hiding behind the car from the cops and you don't understand the context of it, that could look like paranoia. It's not paranoia, but it could look like it, right? And a lot of the people making the diagnoses don't necessarily have that context all the time. And I think that when we look at diagnoses, schizophrenia is the one that's more stigmatized. It's more marginalized. So it's not surprising. It's more readily attached to the marginalized community.
There were a couple of slides that you showed earlier on that looked at all of the risk factors for mental illness that are very much a result of social policy and where society sort of chooses to use resources and where it doesn't. I thought that was incredibly powerful. And then another sort of data point about the poverty rates in children compared to the rest of the population. Now, kids are sort of always treated worse in this society than adults. And it's interesting because while they are only a small part of the population, they're 100% of the future. So I honestly never get it. I just do not fully understand how that can operate this way. And then looking at, the risk of the ACEs and all of those risk factors, the list of those things, and where policy decisions are made. How do we connect that to this beautiful slide with the 4 steps for advocacy? Sort of how do we move that? How do we move beyond that so that we can actually not just medicalize when it's too late and really go towards prevention in a broader way in society? And that's, as you said, that's not just about minority kids. That's really about all kids living in poverty. Yeah. And all kids who, so when you look at that larger proportion, what that speaks to or what that indicates is that we have a social safety net problem, right? So all kid issues are in the context of a family. All family issues are in the context of a society. When you have so many families in that position, we have a social safety net problem. So even if you're middle class now, something goes left and you might not be either. So again, it's one of those things that is a risk to all of us, a threat to all of us, but that isn't always framed that way. And one of the things I brought up with the trainees earlier is I think that at the very minimum, as people who are in positions of privilege as physicians, that we can use our voice, we can use our platforms
We can use how we write about kids in charts, right, to acknowledge these factors that are at play. And we can also redirect people, right? So we have a center for, we were granted a, grant for, I think, a center for Black youth suicide prevention or wellness or something at Morehouse School of Medicine. I'm one of the advisors on it. And I was like, yeah, you really shouldn't spend most of your money on psychiatrists. Just spend it on like school tutors and mentoring programs and things, right? It's up to us to help people understand that and redirect the funds that we get in ways that are more upstream and are going to be higher yield. But it's work. I do think naming adultism is important because it's an ism we never talk about. But in my opinion, it is one of, if not the biggest driver of like problematic public health outcomes in America. And so we have to recognize kids for the underprivileged group they are and start to call attention to it. And I think that when an MD does it, people don't expect that from you. And so it may even carry more weight sometimes. But there's work to be done all around. I think that, and I actually gave a keynote about this at Advocacy this year, which is the training conference for residency training directors, about how child psychiatry should be everybody's problem. It's not just child psychiatrists' problems. Adult psychiatrists should be thinking about, how can I maybe learn more about adolescent psychiatry, or how can I, if I'm in a training leadership role, make sure the trainees get exposed to good child psychiatry experiences. But this is an issue for all of us. And we got to stop thinking about child psychiatry as something for the cat people to worry about. All of us should be worried about it, because you know what happens to those kids? They grow up and they become adult patients with refractory depression and who end up in your ERs and all of these things. So it's a house of medicine problem too.
Any other questions?
Thank you. Thank you so much for your talk right now and also previously for the residents. I had a recent experience where I was talking to a patient who's Black, and he used the word visions and then just kind of moved on with the conversation. And I didn't really know what he was talking about. So I asked him, and he clarified that he was talking about dreams. But it was really surprising to me, because I think if I hadn't asked, I would have just assumed they were hallucinations. And that would have changed the picture a lot. Mm-hmm. So I'm wondering, aside from just having an open mind, being curious, never assuming and asking questions, do you have any resources for kind of like culturally competent care, or just kind of understanding language that people use, things like that could be useful?
Yeah, so I'll kind of answer your question, but kind of not. So the best resource for that patient is always going to be that patient and that patient's family, right? So as a Black person from Northwest Florida, who's a descendant of enslaved American people, my experiences were really different than the people I saw from Haiti at Cambridge Hospital, right? We were both Black. There were some things we overlapped on, but a lot of stuff where I had to ask, like, what are they talking about? and so never thinking that you're going to have a book or a resource. And this is kind of like anti-medicine, right? In medicine, we want an answer. We want to be able to answer the right question, right? Like we want something that's clear cut. But when it comes to kind of culture and identity, it just doesn't work that way. And so what you did was absolutely perfect, right? Asking, being curious, understanding. There's always more to learn. But, there are, I would say, my goal with these talks is never to have you guys or the audience kind of walk away with a bunch of facts. My goal is always not to change what they think, but how they think, right? That you are willing to take a step back and think about, okay, where's the gap between my lived experience and their lived experience? And that you are willing to consider gaps that are not just cultural, but structural, right? How does the world respond to this person differently in a way that could be shaping like their thoughts, their feelings, or their behaviors?
Thank you.
All right. Well, thank you. Thank you very much. Thanks for coming.
Thank you.